wait for one more minute. Yeah, let's wait for 1 more minute and then we can get started. Oh, I can see some familiar names out there. Hey, Anu.
Hey, so good to see everyone.
Yeah, good to see you.
Hi, Anu.
Hi, Christina. Hi, Bibhav. Hi, Pragya.
All right, so maybe we should start now since it's already 6:01 Nepali time. So सबैजनालाई namaste, like welcome to the 4th web series of Nepal mental health research series. And for those of you like who might be surprised to see me and not the usual face, stay हाम्रो अनुको अथवा रितिकाको don't worry, you are in the right link. आज चाहिँ म सवार्द and my colleague Christina, sorry, I have to switch between Nepali and English because I assume Christina still needs to learn more Nepali up there. So me and Christina are going to cover today's session. So our colleagues, our usual colleagues, Ritika, Brandon, and all are in Xiangja right now. So we are covering for them because I guess the internet is very limited up there. So today, the topic of our webinar series is task sharing and implementation of the collaborative care model in rural Nepal, where we have 2 excellent speakers, Dr. Bibhav Acharya and Pragya Rimal, who will be talking about their work about task sharing and collaborative care model, which I believe are 2 of the most important thing that we can discuss in mental health, especially in countries like Nepal. So for those of you who don't know me, my name is Sauharda Rai. Right now, I'm a PhD candidate at the University of Washington, Seattle, and I study mental health and migration right now. I have been involved in mental health research. I was just counting the years, and I realized that it has already been like 8 or 9 years. So that's what I've been doing. A very short introduction about me. Ani, about the webinar, a quick thing, and just bear with me because this is not I do all the time, like and all. So just sharing a little bit information about the webinar. We have the webinar running every month, the 3rd week of every month, and then it's run through collaboration of TPU Nepal, where I have been working for a really long time, and then the George Washington University. So it's a series of webinars that's aimed in capacity building of early career researchers. And then we have speakers from different background and then from all over the world who come to give their talk on different topics. And that said, if there are any topics that you want us to cover, like for example, you want to bring a certain topic or a certain speaker on the aspects of mental and behavior health, please let us know. I will be putting up a feedback form sometimes during the session, and then you can put up things up in there. So the dates and speaker for the event will be sent through emails if you are already subscribed to our emails, or you could follow us on Twitter or on Facebook, and then the events and the dates and the details of the presentation, the webinar will be posted up there. So every month we have this excellent line of speakers, right? And then as today, I will let my colleague Christina take over after a while for more detailed introduction. So a couple of housekeeping before we start formally. Christina already started the recording, but I just wanted to give a heads up to all of you that this session is being recorded, and the recording will be shared to all of you and then also in public. And then also we will be sharing the slides. You can find the recordings and then slides through the email if you're already subscribed, or as I said before, through Twitter and then Facebook as well. So it's an hour-long webinar where each speaker will have 15 minutes each to speak, and then we will have I guess 20 to 25 minutes of Q&A session, question and answer session. So please stay on mute throughout the presentation. So if you have any questions, you are free to type your question in your chat, or during the Q&A session, you could just unmute yourself and then ask the question. We'll try our best to answer all the questions that you have, but if there's something that we cannot cover, please feel free to email us, and then if the speakers are okay, to email them as well. And the most important thing, one of the most important thing is that I will be adding a link to the feedback forms in the chat box. So please make sure that you fill up the feedback form up there. And I think Ritika mentioned something about certification of participation that's been provided to all of you. So once you reach this threshold, I'm not very sure about all of the details, but there is something up there just to let you know. With that said, I don't want to waste a lot of time talking, so I'll just hand over to Christina to do the introduction, and then let the speakers take over.
Hi everyone, my name is Christina Juan and I'm a doctoral student at GW, and it's my pleasure to introduce Bibhav Acharya and Pragya Rimal. Dr. Bibhav Acharya is an associate professor in the Department of Psychiatry and Behavioral Sciences at University of California, San Francisco, UCSF. As the PI of multiple grant-funded studies, he conducts clinical research in low-resource settings with a specific focus on maintaining the quality of care when mental health tasks are shared with non-specialists. He is the founding director of the UCSF Psychiatry HEAL Fellowship in Global Mental Health. He is also the co-founder of Possible, a healthcare research nonprofit organization that has delivered care for over 500,000 people in rural Nepal in a public-private partnership with the Nepali government. He was born in Pokhara and completed 10+2 from Budhanikantha School in Kathmandu. He attended Haverford College and Yale School of Medicine on full scholarships and completed his psychiatry residency and clinical research training at UCSF. I am also excited to introduce Pragya Rimal. She leads mental health research at Possible. She is a global mental health researcher and psychologist by training. She led the successful implementation of collaborative mental health care and research in Assam and Dholaka. In the 2-year study, mental health services were integrated into the primary care setting, and non-specialist clinicians were trained to provide high-quality mental health care to more than 5,000 patients. Pragya is passionate about scaling mental health services to resource-denied settings through research and innovation. Currently, she is leading 2 studies looking at the adaptation and development of a motivational interviewing tool to assist community health workers to engage with non-adherent patients with depression and youth living with HIV. Additionally, as a co-principal investigator, she oversees a family intervention pilot study to address mental health drivers of domestic violence among young women in Nepal. Her areas of interest are implementation research and global mental health. And I'm super excited to learn what they will be sharing. So over to Bibhav.
All right, so I'm going to stop my sharing my thing. So Dr. Acharya, you're free to share your slides.
All right, can you all see this?
Yes, that's perfect.
All right, well, thank you, Soharda, thank you, Christina, and the rest of the organizers. I'm really excited about this. So what we'll be doing is I'll spend the first 10-15 minutes providing sort of an overview of the setting and the intervention that we tested. And then Pragya will describe really the details of the implementation part of the research and the results that we found. And I know, we'll have time for questions at the end, but if something urgent comes up, please feel free to interrupt and I will try my best to respond. So the funding for the work that we're describing is from these entities. So things on the right provided funding for the research part of it, and Possible, the nonprofit I co-founded, and Nyaya Health Nepal, the Nepali counterpart of Possible, and the government of Nepal. These three entities on the left provided funding and support for the service delivery part of the work. So I'll be talking about my career trajectory. I know one of the goals of the webinar is to focus on sort of career development. We'll talk about the positives and some risks of mental health task sharing, and then describe the collaborative care model. So I was born in Nepal, in Pokhara, and I'll never miss an opportunity to show off some pictures of Fewatal and Machapuchre. I took both these pictures many years ago. The one on the right from my window where I grew up. And then I went to Bioquanta School in Kathmandu, completed my high school there, and was kind of confused about what to do in life. Initially thought I was going to be a doctor there, but was honestly disillusioned by the way medicine is practiced in many settings, sort of these 2-minute visits where you just get a prescription. And that just never felt satisfying to me. So I ended up applying to schools in the US, went to Harvard College, mainly because of their sciences program, and they gave me a scholarship. And that's when I got introduced to sort of ideas of public health, research, and I was able to do some internships with public health organizations and really rekindled my interest in medicine again, and decided to apply to medical school. So went to Yale, and that's when the early work for Possible, the nonprofit, began with the other co-founders, and then went to UCSF for my residency training and did my clinical research there as well. So at each of these points, again, these are different decision points that I had to face. And if anyone's interested in digging more into sort of how do you make these decisions about mental health and about health career, I'd be happy to go into that as well. So let's set up the scene for the work that we'll be talking about today. So this is a picture that I took many years ago, and this is the path, this is the road to Assam. As you can tell, a very rural part of the country, out in the western region. When we began our work, there wasn't a single physician for a region of about 250,000 people. The nearest psychiatrist that was full-time was about 16 hours away. The nearest airport was 14 hours away. The nearest ICU was 14 hours away as well. And the region also had one of the worst epidemics of HIV, mainly initially driven by migrant workers working in India, getting HIV from sex workers, coming back and then transmitting it to their wives and kids. And again, it's no surprise that all these social factors kind of compound each other and worsen healthcare outcomes as well. This is a picture from a mudslide during the monsoon season. So this one path that connects Assam to the rest of the country and the rest of the world really was just this very unreliable road. And you can imagine the implications for people, commerce, healthcare. You got people stuck on both sides, and recruitment as well. How difficult it is to get people to work and live and work in a place like Assam, and especially given that the airport is so far away. And a lot of people cannot afford to fly, so they actually end up taking a bus to go to capital, to go to Kathmandu, and that takes about 30 hours each way. So this hospital, Bioquanta Hospital, had been built by the Nepali government about 40 years prior, but for many reasons had never actually seen patients. That there were no services, and was essentially abandoned. And as you can see, a water buffalo had decided to sort of make it its home. There were no people, there were no patients, and this is the hospital that abandoned, vandalized. This is the hospital that our nonprofit started to develop in partnership with the Nepali government, and flourished over the many years. There's a diagnostic lab, there's an in-house pharmacy, surgical services, and a community health workers network as well. This is a more recent picture. So this hospital is where we first implemented collaborative care and then expanded it to Dolakha, where, as many people know, in 2015, the earthquakes destroyed about 85% of the healthcare infrastructure, and the Nepali government invited our entities, Possible and Nya Health Nepal, to expand the model from Bioquanta Hospital to Charjikot Hospital as well in Dolakha. The study we'll be describing will be based in Bioquanta, but the model for mental health, in addition to the overall primary care system, was replicated in Charjikot as well. I saw this boy. He was 16 when I saw him first, and he had been tied up, essentially in a fetal position for 2 weeks because the family didn't know what else to do with him. He was a young, sort of brilliant kid from a Dalit family. The family had a lot of expectations from him, and unfortunately, his behavior sort of became more and more disruptive in school. So the school said he can't come back into school anymore. He kicked him out, and they kicked him out, and then he became more and more unpredictable. So the family didn't know what to do, so they had to tie him up. Took him to traditional healers, didn't get better, and eventually someone sort of told the family, "Hey, bring this guy to the hospital," and I think they have mental health services. So that's how I ended up seeing him. But as you can see, he was actually tied up in a fetal position. They released his legs so he could walk the 3 hours or so that it takes him to come to the hospital. So how does this happen? So, and again, as many of you know, this is not an uncommon sight. People being tied up, chained, caged, even now, especially in rural Nepal. So how does something like this happen? And I really like this quote, which says, every system is perfectly designed to get the results it gets. If you look at these sort of horrific outcomes, but if you look at the system-wide factors, you realize that, of course, the way the system is set up, something like this would happen. And that's the approach we want to take today. So thinking about sort of the system rather than just what's happening in this one particular interaction. And this is, of course, where the task sharing thing comes up as well in mental health. The usual narrative is there's not enough psychiatrists and psychologists. I see people putting in chat, okay, so hard. Okay, so if there's any burning issues, please unmute and interrupt me. So the question in task sharing is often, if you don't have enough psychiatrists and psychologists who end up becoming sort of quite expensive, right? So high cost, but they can provide high quality care. How do you expand access to care in a setting like this? Because if you just keep adding these specialized folks, then they'll be super expensive. So task sharing is trying to sort of get out of this, what's called the healthcare trilemma or the iron triangle, which essentially means you can only get 2 out of 3. If you want high quality and high access, oftentimes it's really expensive. And you can see, you can play around with the various models. So the main model that the WHO has been implementing or pushing for is training primary care physicians and sort of other non-specialists so that you can expand access to care at low cost, because the personnel who are non-specialists end up becoming slightly cheaper, affordable, honestly. And the risk, of course, is the loss in quality. And we found this as well. So we tried multiple models of mental health integration. First, we had what's often most common in Nepal, which is health camps. A psychiatrist goes out, essentially camps out and sees hundreds of patients in a day, goes back every month or so. There are many challenges with that. Continuity of care is really difficult. Oftentimes these camps are expensive and the timing is unpredictable. People might need care in between. And this kind of ongoing high quality care is difficult. And then we had one person, one primary care provider, be sort of the designated mental health person, and that person got overwhelmed because these are high burden illnesses. And then we had the MHGAP program, which we trained all of our primary care providers in. And the challenge with that, we realized, was that the quality of care was actually not very good, which you can't blame the primary care providers for that, because training by itself without ongoing to ensure quality of care. So this trilemma is I hope people can put this in the back of their mind as we think about the challenges, not just in mental health, but like any kind of expansion of access to care. So I'll go through the collaborative care model really quick. Pragya, like I said, is going to describe the implementation research aspect of it. I'm describing the intervention aspect of it. So the patient comes in, sees a doctor or a health assistant, similar to a physician associate or nurse practitioner, and they do sort of a very quick screener. Okay, do they suspect the person has mental illness? Can they rule out a few things? Is it hypothyroidism? Is it anemia? Is it a nutritional deficiency? And after they do that, when they decide, okay, this person needs some kind of mental health service, they'd send the person over to be seen by the counselor in the same day. So this is not come back tomorrow. This is not here's a referral. It's, walk down the hallway to the counselor's office. And the counselor spends a lot of time with the patient, really doing a psychosocial evaluation, and then, implementing some of these validated tools like PHQ-9. And then based on this sort of 30 to 45-minute evaluation, they come up with a treatment plan in collaboration with the physician or the health assistant. So the patient is walked back again the same day to the same clinician that they saw earlier. And then the counselor might say, this looks like severe psychosis or severe depression. I think we need to do both therapy and medications. Or the counselor might say, it seems like so much is driven by social problems, and I will work with the patient to address these issues. So they do this, collaborative evaluation and treatment planning. And then meanwhile, and then this person will prescribe the medications if necessary. And then meanwhile, the consulting psychiatrist who's offsite meets with the counselor and sometimes the primary care providers as well, once every week, to provide what we call proactive consultation. And this part's absolutely key in my mind, especially for the setting that we're working in. And the main difference is, it's not that a counselor says, I have a problem, I'm struggling with this patient, can you help me out? But the consulting psychiatrists, what they do in proactive consultation is they say, tell me about all the patients that you saw, and why did you decide they had depression? Why did you decide to recommend these medications? To do this kind of thorough quality assessment, which is how I learned medicine. This is how I learned psychiatry. I would learn things in the lecture halls, and then I would try it with the patients, but then my attending or my resident would say, explain your thought process so that I can find any blind spots that you may have missed. And then every quarter, the consulting psychiatrist comes in and provides in-person training, and we also have community health workers. So as you can see, this sort of helps us get out of this iron triangle, because the cost and access are maintained by the on-site primary care team. So these are people at the hospital. And the quality of care is maintained by the psychiatrist who's off-site, but spends really half a day a week, which is a lot more affordable from the cost perspective. So this is how we've been trying to sort of get out of this trilemma in healthcare. Quick pictures. So our physician talking to one of the patients. So this is the first thing that happens. Zani Gizi, one of the counselors, talking to a patient. This is the second step after the physician makes a referral. And then finally, another counselor, Bharatji, talking online to the remote psychiatrist. All right, so that's all I have from my side. I will stop, and then Pragya is going to take over. And like I said, I'm happy to answer questions after at the end.
Is my screen visible?
Yes, Pragya, it's good.
Thank you, Saharda. Thank you so much, Bibhav, for setting the stage. My name is Pragya. I have a whole slide dedicated for my career trajectory as well, so I'll keep my introduction short. In the next 15 minutes, I will talk about how we implemented the collaborative care model using an implementation research in Nepal. The outline, I for some reason can't go next. Let me see. Let me try sharing it again, because I can't forward my slides. Just a second.
Can you do it now?
No.
So
Is it?
So I can share your slides, and then you can just tell me when to click next, if that's okay.
Yeah, sure. Thank you, Saharda.
All right.
I'm going to stop sharing.
Okay. So there you go. Can everyone see my slides, not my Pragya slides? All right, sounds good. Okay,
Thank you so
Pragya, let
much.
me know when you want me to. Let's switch to the next slide.
Okay, thank you. We'll go to the next slide. Thank you so much, Saharda. I know this is not the most efficient way to do things, but I'll talk about my career trajectory and then describe the study protocol and dive a little deep into the framework that we use to implement our study and then discuss the results from the study. Could you please go to the next slide, Saharda? Thank you. The funders and partners are the same as Bibhav mentioned, so we can skip this and go to the next slide. When I found this picture in my gallery, I thought it would be a nice way to talk a little about my career trajectory and how I am working as a global mental health researcher. So around middle school, I started developing interest in psychology. And I didn't know anybody who was doing psychology at that time, or even anybody who thought psychology was a discipline that could be studied and have a formal, like, training and career in. So over several years, I would spend a lot of time self-studying about psychology and mental health. Then I moved to India for my bachelor's and master's in clinical psychology. I got back to Nepal in 2016, and since then I've been working with Possible as Senior Mental Health Research Manager. In this role, I lead the studies conducted by Possible, mental health studies conducted by Possible. Apart from the study that we're going to talk about today, there are several other studies ongoing and in the pipeline. So I've been part of really interesting and innovative studies at Possible. So in the long run, my interest is child mental health. I want to continue working as a global mental health researcher and an implementation scientist, but focusing my interventions towards child mental health. So it's a long way to go because I've chosen a path of a researcher, PhD, postdoc, and all the interesting things are in the pipeline. So that's why I say I have a long way to go. Let's talk about the study protocol. Thank you, Saharda. That was quick. So we implemented a collaborative care model for depression in rural Nepal. This was a 2-year study. We started in 2016. It's a mixed methods implementation science study. So acknowledging that we may have some audience who are not familiar with the research methods, let me talk about mixed methods and implementation research. As the name suggests, we're still here. As the name suggests, mixed methods is a study research method where we use quantitative as well as qualitative data collection. For our study, we had clinical outcomes for patients and focus group discussions and key informant interviews from the providers. Implementation research is a method in health research mostly, where so we know that what works based on evidence from randomized controlled trials, but how does it actually translate into real world is the question, because implementing a collaborative care model in Assam may look very different to implementing a collaborative care model in another high resource setting. So that's what we did. We conducted implementation research, and we can forward to the next slide, Sohada. In the next slide, we'll talk about how did we exactly do this. A little background to this is that, and Bibhav has mentioned this already, so I'm not going to talk much about it. So the primary care providers in our setting, they don't necessarily have mental health training, or they have very limited mental health training because they are based at the OPD. They also don't have a lot of time to talk to the patients. They spend less than 5 minutes, and it's all designed that way. So we were trying to introduce something that was more time consuming for the primary care providers and also something new. So we very carefully curated this, worked within this framework. It's called the COM-B. C is for capability, O is for opportunity, and M for motivation. The idea for this framework is for a desired behavior to take place, we need to have we need to enhance capability, opportunity, as well as motivation, so that people are more inclined to conducting the desired behavior. In our case, for the primary care providers, the desired behavior was to screen, diagnose, and treat mental illness. And for them to do that, we enhance their capability through training, knowledge-based and skill-based training. And this is important because a lot of times when new interventions are being designed, we focus on building the capability or the capacity, but we don't ensure that other parts are functional. So if we go next, Soharda, you should be able to see the examples on the left-hand side. Yeah, thank you. So first, we wanted to enhance the capability through training, including how do you screen patients with depression, or how do you even conduct a patient-centered interviewing. These were all new things for the primary care providers. After that, we wanted to make sure that we had created an environment where primary care providers could practice what they had learned. So if you go down to opportunity, this is where they have access to a consultant psychiatrist in the program, or access to the counselors or protocols or electronic health records and medications. So all these would enhance the opportunity for them to practice the new behavior. And with capability and opportunity in place, they would feel motivated. Motivation again can be internal or external. So external motivation could be maybe the clinical leadership encouraging the primary care providers to practice mental health, or internal motivation could be something like when you see a patient doing better, you feel motivated to continue the work that you're doing. So we assessed the program within this framework, and also conducted focus group discussions and key informant interviews to see what was going on and how things were playing out. If we go to the next slide, thank you. So within the collaborative care model, when we implemented it, there were some challenges. I'll focus on maybe the two challenges for now. The first thing that we noticed, that we experienced, is orientation to team-based culture. So this collaborative care model needs a team that is working together to make sure that the patient is being provided with high quality mental health care. So we know what team-based culture is, but because this is something new, it was a little challenging for people to practice team-based culture. What I mean by that is there was a little hierarchy between prescribers and non-prescribers, between clinicians and counselors. Everybody was doing their own part, but it was not happening in a collaborative manner. So in order to resolve that, we conducted a monthly mental health integrated conference, where the goal was to get multiple teams involved in care to talk about a patient. So the community healthcare workers would talk about the maybe economic conditions of the patients, the counselors would talk about what they did, the primary care providers would talk about the treatment, we'd even talk if the supply chain was in place or not. So with all this, people got an idea of what the other team members are doing to make sure that the patient is receiving care. This was important because after these discussions, people really started understanding the value of other team members and started engaging with each other more. The other challenge that we faced is, so in order to enhance the opportunity, we provided access to a consultant psychiatrist through weekly case review, proactive consultation that Bibhav mentioned. But a challenge that we ran into was, each time primary care providers had some question or some uncertainty, they would just call the consultant psychiatrist. So we wanted the primary care providers to feel supported, but at the same time, we also did not want to extremely rely on the consultant psychiatrist for like minor things. So in order to streamline that, we created a mechanism where each time there was some uncertainty at the clinic, the primary care providers would discuss with the counseling. That would also help with some engagement and team-based work. And together they would call the consultant psychiatrist whenever they had an emergency consultation. So they felt supported, there was teamwork, and the psychiatrist was also not burdened. If you go to the next slide, this is a mixed method study, like I said before. So we had clinical outcomes and also providers' perspective. To measure the clinical outcomes, we administered PHQ-9, which is a WHO and also validated patient health questionnaire in Nepal. So we administered the PHQ-9 in the baseline and in the end line for the patients who were enrolled in the study and getting treatment for depression. And the results of this was that we observed substantial clinical response in 49% of patients with depression. So what this means is 49% of patients who were receiving care for depression at the clinic, when we compared their PHQ-9 score from baseline, it had decreased by 50%, or they had reached remission, which means their PHQ-9 score was less than 5. Technically, they no longer had depression. The other interesting thing from the study is 85% of patients with depression, with moderate to severe depression, were prescribed antidepressants. Now, before the collaborative care model, when people had symptoms of depression, they were prescribed with vitamins and painkillers and not antidepressants. So because they were also provided with antidepressants, they also met clinical response. And this is alongside with therapy and counseling and psychosocial support that the counselors provided. If you go to the next slide, I will talk a little about the provider's perspective. We gathered providers' perspective through key informant interviews and focus group discussions. And this was done on a regular manner because we wanted to get the feedback so that we can feed it back to the program and make some improvements as well. When we conducted these focus group discussions and key informant interviews, we wanted to make sure we were going back to the COM-B framework and seeing what the providers feel about the program. At the end of the program, we found out that because of the training and support provided, the primary care providers had improved self-efficacy and clinical knowledge to treat mental health problems. Similarly, because they had access to counselors, psychiatrists, diagnostic tools, they also felt like they had more opportunity to use what they had learned. And finally, because they could see how the patients are doing, they also felt motivated to continue the work that they were doing. If we go to the next slide, there is a quote that I would want to share with all of you. I'm going to read this out from the screen. This is from a primary care provider who says, "We had limited knowledge about mental illness and were scared that those patients would harm us. Now we can take care of them. We know how to talk to them and the fear has decreased." I find this quote really powerful because I think it gives us a comprehensive idea about how even healthcare providers can have stigma against mental health problems, and like they are even scared of patients. But after the intervention, when we do something correctly, when they have supervision, when they have the right kind of training and support, they are able to reduce their stigma, but also provide high quality care for patients. Similarly, if you go to the next slide, this is from a counselor who has touched upon the relationship they have with the consultant psychiatrist. So the consultant psychiatrist is off-site, but because they have regular proactive consultation, the counselor felt really supported. And this in turn increased the opportunity for them to provide counseling. If you go to the next slide, this is again a quote from a counselor who shares that she feels extremely motivated when patients tell her that she is feeling better, when the patient feels better. So what happens generally is patients try a lot of things, they go to a lot of pharmacies, a lot of tests, and they don't feel better. But when they get the right kind of treatment and they would share with the counselor about how they are feeling now, this affirmation that patients share with the counselor motivated them to continue the care. If we go to the next slide, which is the conclusion, through this study, we were able to enhance providers' perception towards mental health and increase the quality of care. Overall, we observed significant clinical improvement in patients with depression. We're able to provide care to more than 5,000 patients through this study. And finally, this is something that we strongly recommend for other low resource settings as well, where there are many challenges to accessing high quality mental health care, using an implementation research that allows a lot of contextualization and adaptation as well. Something that's not in the slide, but I do want to mention, is that the study ended in 2018, but the care continues. The mental health program now has been fully adopted by the hospital system where it started, and patients continue to receive the high quality of care. And that's really the goal of the research. We want to develop something that's sustainable as well as scalable. I'm going to stop here, and thank you so much, Sohada, for sharing the screen. Thank you so much. Oh, and those are, if you scan this, you can get a list of publications from this particular study. Thank you.
All right. Thank you, Pragya and Dr. Acharya. That was such an excellent talk. And then the way that you explained the collaborative care model, Dr. Acharya, that was very, very easy. Like way easier than I learned in textbook and in my lectures. So thank you for that. And then Pragya, that was such an excellent presentation about like how you use that particular framework to implement actually in Nepal. So I'll just put out the screens up here. My share screen up here so that you could access the publication here. So we have 20 more minutes. So it's think enough time to have a series of Q&A. So I will start with the questions that has already been raised in the chat box, and then we can move into the session where you just unmute yourself. So I will start with a question. I think one of the question has already been addressed by Dr. Acharya. So the next question is from Nauraj Upadhyay. So Dr. Bibhav, I would be interested to know the success and challenges of collaboration among stakeholders in your collaborative model. What are the key takeaway messages from your study? So that's the first question for you.
Yeah, thank you. So we've tried to describe some of this stuff in the papers as well, but I think, and Pragya is going to be the expert in answering that question. So please take over after my quick response. I think team-based care is a big challenge for people who are used to doing sort of independent. I'm going to see patients, and then when I'm done, or if I need help, I'll refer them, as opposed to sort of let's get together and work together, which is a much better model for mental health and any kind of chronic care even. So I think that the main challenge was, team-based care, but at the same time, and that takes about 6 to 12 months for the team-based care culture to set in. But at the same time, once you set that up and people feel comfortable, the primary care providers actually enjoy having this, sort of set up around them that they can lean on, like the counselors if they need them, the psychiatrists if they need them, and the ongoing training and supervision. And that's a huge challenge especially for the primary care providers. They feel isolated. They feel like they're by themselves, taking care of all these different illnesses, and every program keeps adding more and more things. So I think that would be the main sort of takeaway from my side. But Pragya, go ahead, because as you oversaw the implementation on the ground.
Thank you, Bibhav, and also thank you for the question. I think related to team-based care is something that we experienced, and it's mostly about the counselor versus primary care providers who have completely different training. And we know that counseling and therapy and social support is important to take care of your mental health. But even on the clinic, there would be like this unsaid hierarchy that primary care providers who are prescribers don't think that the counseling is needed, or like counselors think that counseling should be enough and you don't necessarily need medication. But I think it was important to establish that both of this go hand in hand. I also see that there's a follow-up second part to this question, which is what are the key takeaway for the study? And I quickly wanted to comment on that. I think the key takeaway for me as an implementer of the study is to have somebody, a focal person from the medical team, to be in charge of the mental health program on site, because the research period is going to get over, but the goal is scale up and sustainability. So if you have somebody from the clinical team or from somebody from the leadership team who really owns up this program from day one, I think that helps in the long run on how the program is embedded within the hospital system. So I'll stop here. Thank you.
All right, thanks, Bibhav and Pragya. So we have a hand raised. Nachiket, I hope I pronounced your name correctly. Yeah, you could just unmute yourself.
Okay, thank you. This is my second question, so I'm happy to defer to anybody else who has a more burning question. But if there's nobody else right now, I'm happy to go ahead.
Yeah, there are questions, but if it's a short one, then you could just go ahead.
Okay. So the question I have is, this is a beautiful study, and we heard from Pragya some time ago as well about this really high quality work. As somebody interested in broader primary care, how far do you think this can go? And kind of an additional question there is, should we then say, let's start with primary care, then add things? Or from the very beginning, make it multidimensional? Because otherwise, there's a concern in my mind that it will be, we're adding too many vertical programs and not really thinking about the patient as a holistic person, and pursuing horizontally. So that, I don't know if my question was clear, but that's kind of the issue in my mind. Thank you.
I can quickly respond to that, but there's clearly a lot more to be said about what you said, Nachitek. I think, and the paper you sent, I just quickly skimmed it. I think there are many things. So one is, first of all, obviously it depends on the context, right? So the paper is from Alaska, and the main difference I've seen with mental health in the US and a lot of low-income countries is that, so I went to med school here in the US, and I could hate psychiatry, and I still have to do 4 weeks of rotation in psychiatry, and I have to learn that. In many countries around the world, psychiatry, mental health, sort of any rotation is actually sometimes optional, or sometimes it's very short. So the primary care provider's own competence and comfort and stigmatizing attitudes are very different, depending on the kind of professional training that they have received. So that will create variation in the quality of care and the comfort level. To the second point about where does this go, and again, we'd be happy to learn about additional models. Our experience after implementing 4 or 5 different types of integrated mental health primary care systems, we settled on this, and we found this to be the most compelling because the primary care providers actually felt supported. And to your question about patient care, patient-based system, patient-centered systems, so the history of collaborative care actually comes from the chronic care model, which is one of the few patient-centered interventions, especially for chronic care illnesses. And the patients in our studies, I know most of the results we showed were from the provider side, the patients finally felt that people were listening to them, because they were not doing sort of these 2 to 3 minute medication prescription only visits. They were able to sit down with a counselor who was able to really talk to them for 30 minutes, 45 minutes and do ongoing care, which I think was much more patient-centered than how things were in the past. But and in terms of scaling up, again, cost effectiveness analysis is going to be the next step. How expensive is it? And again, looking at the perspective from the patient side. So I think what you're raising needs to be addressed in future studies for sure. Thanks for that question.
Thank you to both of you. So I have another question, very interesting question by Dr. Bibhav. So both of you talked about the pharmacological interventions and all, but could you also talk about how did you deal with explanatory models, like the way that let's say how depression is understood in that location, some of the examples that he gave was Tintero versus depression, how did you look at that? And then also how you looked at the local traditional healing mechanisms and education around it or against it. So someone who are the defaulters of pharmacotherapy. So could you talk about it? Especially I assume there were some kind of challenges when you were working in Assam.
I can quickly respond to the traditional healing part, because I have something to share on that. So the way we dealt with this is, of course, the traditional practice is to go to traditional healers who are a very strong part of mental health care, because people with mental health problems don't know where to go because it's not visible. They go to traditional healers. And I think the traditional healers also is really a belief system. So because the patients had, people would have a lot of problems and nobody would listen to them, we have a habit of dismissing people's experiences, telling them to not think about it. But I think what traditional healers do is they sit down and listen to the people who have those problems. And I think that really helps. In our study, what we did is we knew traditional healing is a big part of mental health care in the region that we were working. So we like really primed our primary care providers and counselors to talk to the patients about, like to tell the patients to continue going to traditional healers if they are already going there, right? But because we don't want the patients to feel like we don't understand the experiences. If traditional healing is making them feel better, then go ahead with it, but don't stop taking medicine unless you talk to the doctor. So that's sort of the approach that we use. Do what makes you feel good, as long as it does not harm you.
Thank you, Pragya. Okay, so moving on to next question. So I'm just going to the question based on who asked it first. So Yashu Pokhrel, I think this is a question for Bibhav Dai. So as a PI based in US, can you please give us a sense of how do you manage your time and how you do all of these things? I guess in Nepal, that's what he meant to say.
Yeah, the short answer is have incredibly competent and driven and motivated people like Pragya in Nepal. And my job primarily is to support the team in Nepal. It would actually be interesting, I think, to hear from Pragya's side, what is sort of helpful and what is sort of missing as someone who is living in Nepal and where the PI is not there. And that I think would be helpful as well. But yeah, the short answer is having a great team in Nepal.
Thank you for putting me on spot, Bibhav. But I think what's really important is engagement and ongoing supervision. Like we've introduced supervision in the collaborative care model, but we also want to make sure that the team in Nepal feels supported. There's open and transparent communication. We run into a lot of challenges, but I think it's important to share the challenges with the PI in a really non-judgmental and open way. And I think that really helps, having structured mentorship and supervision.
Yeah, now for me, someone who has been in Pragya's shoes before, I second that, Pragya. It's great to have like great mentors and then great PI like supporting you when you're doing things on field. Okay, so the next question is again from Dr. Paudel. So that's a question for Pragya. So do you give additional incentive to the health workers to do the additional work, or like how do you motivate them?
This is an important one. I think the answer is going to be a bit long, so please bear with me. I think like how we go into this whole conversation about we want to introduce collaborative care model or we want to integrate mental health care, this is something new for them. I think that depends, because like what happened before the collaborative care model was implemented, people still had aches and pains, they still had symptoms of depression, they still went to the primary care clinic. So it's not like we were giving them additional work. The patients, the people were still going to the hospital, but nobody knew what to do. So what happened in turn was they would give painkillers, they would give vitamins. The patients maybe would feel better for a few weeks, they would come back and they would reach like a bottleneck because nobody knows what else to do. So that's where we came in, saying the patients are already coming to the hospital. We're not like creating these patients for you. They're already coming to the hospital, but what we're doing is we're trying to support you by this program. You'll have counselors, you'll have the consultant psychiatrists, and it's going to be a teamwork. So I think that's how we primed the primary care providers in getting them on board with the program. And no, we did not give them any additional incentive. It was mostly just like motivation and persuasion from the clinical leadership, because they were on board as well. We had much more meetings than we had anticipated because that was important for engagement, but we did not provide any additional incentive for the primary care providers or any health workers.
Pragya, I'm sorry, I'm jumping in. Can I ask one more question? I was the one who asked the question. It's like, so typically, we don't have counselors in primary health care. So I guess my kind of a question was also around, if you had an incentive, how did you get counselors into the primary health care?
So what we did was, like you rightly said, we don't have counselors integrated within the primary healthcare system. And because this is the organization that we sort of managed, it was on us to hire counselors. But also we could not hire like really highly skilled counselors because we also want the program to be sustainable. So what we did is, again, we conducted focus group discussions with the primary care providers and listened to them, like what do they actually want from the program, from integration. And there was a lot of interest among the primary care providers, especially the HAs who wanted to be trained in counseling. So instead of hiring somebody else and like, getting them on board to learn about the culture, the team, the care, we trained the health assistants in-house for counseling, and then they would come back and then provide care as a counselor. But that's an important point because we don't have counselors integrated within the health system. So I think what we have to think about is, should we introduce counselors in the health system, which may take a lot of time, or should we create like, in-house capacity building training or programs that can help interested and motivated people to conduct counseling at the clinic? I am not sure if I answered your question, so please feel free to ask another
No,
follow-up.
brilliant, brilliant, because I'm learning. I've been away from the country for 20 years. And when 20 years ago, when I tried to do that, nobody was interested. It was an additional task for them. And now you tell me that they're interested. So this is fascinating. Brilliant. Thank you.
Thanks, Pragya, for the explanation. So I think the next question, Subhada Soti, was about challenges, and I feel a kind of it has already been addressed. So I'm just going to switch gears and then move on to Drishti's question, which is very different from what we have already heard. So great presentations, totally agree. So I'm just curious if you have done cost, utility, or effectiveness analysis for the intervention as you talk about cost, quality, and accessibility. All right.
A great question for a future study. We have not done formal cost effectiveness analysis.
Right. Thanks, Dr. Acharya. So we have like 4 minutes of time left. So I think we have time for one more question. So I'm going to combine Asrita's and Prasansa's questions together, where they talk about like Prasansa talks about over medicalization of mental health problems. So are there any support supervision mechanism in place for improving quality of psychosocial service? And then also on adding on that, Asrita's question on how do you monitor the prescribed antidepressant or other clinical trials? Yeah, and then she has her experience in Rukum up there. Sorry, I didn't read the whole question. Just try to make it short for the sake of time. You get 1 minute, 1.5 minutes to answer this.
Bibhav, because it's medication related, I think you'd be better answering that question.
This is exactly what happens. You end up with a psychiatrist. So Prasansa's question is absolutely important. And I think one challenge is that the number of specialists, psychiatrists available in a lot of low-income countries is actually higher than the number of PhD or other sort of advanced counselors to provide the counseling and support. And that is a huge problem, as we all know, and Prasansa has been pointing out really well. What we did is, in a way, having the psychiatrist provide supervision to the counselor, who cannot prescribe, by the way, only the physicians can prescribe. And that actually is one check and balance against over medicalization, because I think one risk, if you have a psychiatrist directly supervising the primary care provider, there's a lot higher risk that they will just default to medications because that's what they know. But I think you're right. It's a huge gap of having sort of highly advanced, highly trained counselors who can provide this supervision. What we did is we actually supported our psychiatrists to learn a lot of the counseling techniques. And he fortunately, he also has a fellowship in addiction, so he was comfortable with motivational interviewing, a lot of patient-centered counseling techniques, and not just a medical model. But this is a really important caution. But the question about how did you sort of monitor the antidepressants? a huge part of this kind of chronic care model or collaborative care model is having reliable information systems. And again, which is again a huge challenge around the world. It is really difficult to assess quality of care if you don't have appropriate documentation. Now, it doesn't have to be fancy. It doesn't even have to be electronic. If it's electronic, of course, it's better. But having some way to sort of say, have the patient's name, age, what their PHQ-9 score is, so that you have a sense of how well they're doing, and then which medications were prescribed for how long. Just a ledger spreadsheet, even on paper, is absolutely essential. If you don't have that, if you go by memory or sort of what you think, then it's not going to work. So yeah, I think information system has to be part of the infrastructure for this.
All right, thanks, Bibhav and Pragya. So just for the sake of time, I'm not going to take any more questions, but I think we have some more questions left. So if you want to carry on, just email. I think it's fine for you to email Pragya and Bibhav, right? So just want to make sure that I'm not speaking for you. All right, so thank you for such a wonderful presentation. I think this is just an excellent example of how you how you do a research and then use that as an implementation, how you implement it, and then how do you just, do it in a very sustainable way and all. So I will hand it over to Christina to summarize, and then we can formally end the program. But thanks everyone. Yeah, Christina, it's all yours.
Oh, thank you. Thank you so much for this excellent, for me, early morning, and for you, evening. I think one of the big takeaways that I keep thinking about is this importance of support and encouragement and collaboration. So thinking about the team-based model, thinking about patient-centered interviewing, those are some of the things that have resonated with me. So I'm really excited to follow the work that you're doing and see how this evolves, and then how it is integrated into health systems in an operational way, because all of these values are really important. But how do we see it in practice in a sustainable way? So thank you so much for all of your time. And as Soharda said, if you have any additional questions, feel free to share it with Pragya and Bibhav, and we'll leave it at that. I'm going to end the recording now, but also a reminder to fill out the feedback form if you're interested.
Yeah, so that's the last heads up I wanted to give to all of the participants. There's a feedback form that I just put up on the chat box. Like if you just scroll up there,